Okay, this is the Module 5 webinar, and in reference to the assignments that are due this week, one of those is the article review, and the second one is the disability resources framework that I've asked you to turn in on the discussion board. And as far as the article review is concerned, I said it just a minute ago before the recording went on that I'm a little bit negligent with getting more than a little bit negligent. I'm very negligent with getting my papers graded, but I'll get those done as quickly as I can. And I haven't graded all of the Article 1s, so it's hard to say, for some of you to know what is expected for Article 2. But I will say this about my grading style. If you put in a good effort and it looks master's level quality to you, it's probably going to fit the standard for me. I accept a lot of different styles of work, and so I wouldn't get real hung up on format, and know that that I'm pretty lenient with what I accept for the style of work that you put in. I'm not, like I say, I'm not real hung up on APA format, things like that. That's not what I'm looking for. I'm looking for quality within the work itself rather than those little bits of format. So put in a good review of the article that you've found, and if you make a mistake or two in the formatting of the APA style, don't let that hold you back. That's not going to keep you from getting a good grade. My theory is on a master's level course, if you put in good work, you're going to get a good grade in the course. Most of my students make A or Bs. A B would be less than good work. Very few students make Cs in my class. I only have a very few students who ever fail a class. The students who fail are the students who don't do the work, who don't do any work. Those are students who fail. Otherwise, students make A's or B's for the most part. I occasionally have a student that makes a C, but that's a rarity. You can't make a C and continue in a master's program for very long at the College of Graduate Studies level at Tarleton. And so I look for students who are making A's and B's, and less than that, I'm going to speak to you about it. And sorry, nose is itching. So less than A or B work, you're going to hear from me about it, and we'll talk about what's going on with you. D or F work, you're definitely going to hear about it. You're going to those are the people who aren't turning things in. I mean, like turning nothing in, and you'll definitely know if you're in that category. So and those of you who are on the screen right now aren't in that category, or you wouldn't be tuning in. So any questions about that? Yes, Candace.
I'm sorry, my Zoom kind of froze for a minute while you were talking about the article review.
Yeah.
So we have to find the article through the Tarleton Library. Is that correct?
You don't have to find it that way. You can find an article however you want to. Yeah.
Okay.
Just cite the article that you find. Cite the source so that I could go and find it myself if I need to verify that it's actually an article, that it's it's something that's out there in publication from a reputable source. Okay.
Okay. Thank you.
And put your citation so that I can find it. Okay.
Yes, ma'am.
That's what I want to know. And let me say this about that. Certainly I would expect that anybody who's doing master's level study, and this is why I really enjoy the primary focus of the work that I do at Tarleton is all master's level students. I teach one undergrad course per semester. And we have switched where I'm now teaching only senior level undergrad courses, which I really like now. So everybody I'm teaching is either nearing the end of their program or in the master's program. And those are people who are serious about their studies. They're career bound, or they're already in their career. I have taught sophomores and juniors, And that's a whole different mix of people. And I have to talk to those people a lot about the ethics of our field. I try not to talk too much about ethics with my master students. Now, when I get into the diagnostician program, I talk about the challenges of the ethical challenges that you find yourself faced with in that realm of education. But when you're a master's student, I certainly expect that you are at a level in your career where you won't be tempted to do a lot of, cheating, things like that, plagiarism, things like that. I have had that occur twice since I've been teaching at Tarleton, and I'm in my 11th year now, or maybe my 11th or 12th year. And I've only had that happen twice in the master's program. I've had it happen several times at the undergrad level, but in the master's program, it's only happened twice. And those are people who were in the diagnostician program, and I've had to, see them out of the program, because if you don't have the moral fortitude to do your own work at the master's level, then I don't think you've got the moral fortitude to work with children at the level that we do as diagnosticians out in the public schools, and deal with test scores and the challenges of holding tight to what's right and wrong in a testing session, a testing setting, some of those kinds of things. So my expectation is certainly that when you're given something like an article review, that you will get a real article, that you will actually do your own work, do your own review of it, that kind of thing. So I don't do a lot of, plagiarism testing, checking, that kind of thing, because my expectation is that as you do that kind of work, I'm holding you to a standard of honesty that that your employer would hold you to in the work setting, since you're already employed. At least for the most part, our master's students are, and that's my expectation. So that's just a little bit of how I feel about some of the assignments that you have in this course. Okay, so let's talk tonight about intellectual disability, and for just a short time, we'll talk about speech impairment. But I did not get to talk about emotional behavioral disorders last week. I didn't get my computer back online, my work computer back online at home until today, when my husband got back home and worked on it for me. He's been out of town for about 2 weeks. And so he got that going back for me today. And so what I will do is, in the next few days, week or so, I'll try to do a webinar just on my own about Chapter 7, emotional behavioral disorders. I might even let my husband do it. His area of expertise is emotional behavioral disorders. We met in the graduate program at University of North Texas. That was his area of specialization, while mine was evaluation and learning disabilities. And so he has taught several courses at Tarleton, and he taught a bunch at UNT and TCU. And so he is he's a bona fide professor himself. And so I may let him do that webinar as a guest speaker, and then post that if I'm not feeling very well in the next few days. But it'll be the one that correlates with our textbook. If you're taking the next mini-mester, the next 8-week session, the behavior class, EDSP 5311, I think it is, with me, that starts in March. I let him help me a lot with that one, because it is right up his line of expertise. He has taught emotional behavioral disorders, in the trenches in the classroom for a long time. And so I'm just putting a little plug for that. If you're not already signed up to take that, you might be interested in doing so. And that starts in March and runs through the rest of the long semester. And I kind of like to tag team that one with him a little bit. He doesn't get any credit from Tarleton, but I figure it all goes in the same bank account for me. And so I let him help me with it a little bit since he's got so much expertise there. And we have a lot of fun. Sometimes we actually do the webinar together, and I ask him questions, and he gives some answers from his field experience as an expert there. So that's a fun thing to do. But he may be the face that appears, so when a fat-faced a white guy shows up on the screen, you'll know that that's the other Dr. Cavan. Okay, but he wouldn't mind me saying that either. That's what he identifies himself as. Okay, so let's see. Let's talk a little bit about intellectual disabilities. Now, this is actually one of my areas of expertise. Well, all of special ed is, you all know that, but ID is in particular, and I'm going to share my screen, and we're going to talk about Chapter 8 a little bit. And let's see. I'm going to start on slide 5. And this just gives the IDEA definition of intellectual disability. And this is the way it reads: significantly sub-average general intellectual functioning existing concurrently with deficits in adaptive behavior and manifested during the developmental period that adversely affects a child's educational performance. Now, you know that last phrase is part of every disability definition. It has to adversely affect a child's educational performance, but generally intellectual disability will do just that. This is the category that we used to call mental retardation until we changed that terminology in 2015. Now, that seems pretty recent to have changed that terminology because the term retardation or retarded has been out of fashion for quite a while. But we didn't make the official change until that last year of the Obama administration. And in the fall of that year, in December of that year, is when the law actually changed, and we took the term retardation out of the official definition of intellectual disability and changed it to what it is today. It was called Rosa's Law at the time, and it just been integrated into IDEA. But it occurred in December of 15. And a lot of states had already begun using the term intellectual disability informally before that, but it became official at that point, and states had to change their language at that point in time. So what does sub-average mean? Well, we'll see a bell curve here in just a minute, and that'll be a good descriptor for us. But anything at the IQ level of 70 or below is considered sub-average in Texas. Now, I say that because some other states consider 75 or below to be sub-average. And I think that's why this definition is a little bit fuzzy when it comes to the description as sub-average, because it gives states the flexibility to define exactly what sub-average is according to their preference in their own particular state. But in Texas, we define sub-average as 70 or below. Now, not below 70, but 70 or below. And so an IQ that falls in that range is considered the appropriate IQ. But you have to have more than just a sub-average IQ of 70 or below in Texas, or in any state for that matter. You have to also have what we call deficits in adaptive behavior. Now, you see it says deficits, so that means more than one, and more than one means two. So two or more. deficits in adaptive behavior. Now, this is the only thing here that defines how many deficits. Deficits mean two or more, plural deficits. And in Texas, we define that as two or more deficits in adaptive behavior. And I'll show you in just a minute a list of the types of areas of adaptive behavior that we look at. And it has to be manifested during the developmental period. Well, what is the developmental period? Well, that's the age at which a child is considered to be developing. And that is, a lot of people think, well, that's, before they get to school. No, it's anything 18 or below. So basically public school age. Now, we have kids that are still in public school at 19 and kids in special ed who are in school up to 22. But the developmental period is considered up through 18. So it has to have onset during that period of time before the student turns 18. And it has to then have an adverse effect on their educational performance. So this is the definition of the American Association of Intellectual and Developmental Disabilities. And this is their definition. It looks very similar. How you assess it, the areas that have to be assessed, strengths as well as limitations have to be considered. You've got to describe limitations and how you're going to support them, etc. I don't belabor this too much because it doesn't apply to what we do in Texas. The definition that appears in the Diagnostic and Statistical Manual, very similar, encompasses conceptual, social, and practical dimensions. Doesn't rely a whole lot on IQ, but when we get to the school systems in Texas, we rely on the IDEA definition. So that's where I like to put most of my emphasis. Now, here's the prevalence. According to Marilyn Friend, our textbook author, we've got 0.73% of all school children. Then when you consider the group that nationally we consider developmentally delayed, we add another 0.21%. The AAIDD estimates 2.5%, and this comes closer to what you would expect on the bell curve. What we would expect statistically is about 3% of the population. The CDC estimates 1.1% of school-age children. There's not very much research on gender differences, but boys usually are a little bit higher, represented at greater numbers than girls. This last bullet is critical. African-American students are 2.48 times more likely than others to be identified, especially boys. Now, do you think that African-Americans are actually 2.5 times more likely to be ID, or do you think they're just more likely to be identified in our school systems? We usually think it's probably the latter. We over-identify our African-American students, and we particularly over-identify our boys. And so this is something that those of you who are planning to be evaluators need to really be cognizant of. When those children who are African-American are being referred for disabilities, we've got to be especially careful about the tools that we're using for identification. Some are biased against our African-American populations, and sometimes our evaluators are biased against African-Americans. And so we've got to be extremely careful during that process. So what are the causes of intellectual disability? Well, we've got several. We've got some that are prenatal. We've got some that are what we call perinatal, that happen during the birth process, and then some that happen postnatal, after the birth process.
I can control that. Now, I can't control
Hi, DJ. Mute your
what you're
mic.
getting. I don't know if you understand it or not, but I've darn sure delivered it.
Oh.
But even with this,
DJ,
it was hard for me. You all were really engaged.
Mute.
And I don't want to take your time up, but it was hard to.
I'll mute you. There we go. Okay. There we go. Okay. All right. So we've got prenatal, and those are things that happen before the child is born. So there's a lot of chromosomal abnormalities that you've probably heard of. Certainly, we all know about Down syndrome, Fragile X, Prader-Willi, Martin-Bell syndrome. A lot of those you've probably heard of, seen students in your school that have them. Fetal alcohol syndrome, PKU is a response to a protein that can be in a child's diet. There is a medicinal response that we can have to PKU that can take care of that to some degree if it's caught early enough. Toxoplasmosis, this is a parasite that comes from cat feces, and it can cause complications in a pregnant woman that can then be transferred to the fetus. And so there's lots and lots of causes that can happen prenatally. We've got an increasing number of ways to catch these things prior to the birth of the child. And so it seems that more and more, just anecdotally that I'm seeing, more and more moms who have babies with intellectual disability know about it before the child is born. You all may have seen that amongst the people that you know, maybe in your own families, friend groups. I've known 2 of these just in the last few months, that young moms that I know who have had babies with intellectual disability, but they were aware of these complications before the babies were born. Perinatal things that happen as part of the birth process. Babies that are born prematurely, critically prematurely, oftentimes have intellectual disability. Babies who have birth injury, oxygen deprivation at birth, or other types of birth injury that can occur during the birth process, sometimes suffer intellectual disability. And then things that happen after the birth process, encephalitis, lead poisoning, other kinds of brain injuries that happen after the birth process. So there's the bell curve that I was talking about. And right there in the middle, that 34% on either side of the 100 is the average population, IQs that fall in the average range. And then we add that 13.5% on the next side of that. And that includes all of the normal IQs. And so anything from 70 to 130 is our normal population. That's our low IQs all the way up to our high IQs, but not our abnormal IQs. And so below 70 would be our abnormally low IQs, and anything above 130 would be our abnormally high IQs. We talked about gifted and talented a couple of weeks ago, and those fall above 130. Our abnormally low IQs fall below 70 or below. And then we've got these ranges below the range of ID in the ID range, and we've got them at 15-point increments. Those are standard deviations, statistically speaking. And so that first bracket at 1 standard deviation below is the mild range, and that's the first 15 points below 70. So 55 to 70 is considered the mild range. The next range, 30 up to 30 points below, is considered the moderate range. And then the next range below that, another 15 points, is the severe range. And then anybody that's in the 25 point IQ range and below that is considered the profound range of intellectual disability. And so what are some of those characteristics in there? Well, kids with an IQ in the mild range oftentimes, well, frequently are able to be successful in a school setting, many times without classes with other students. A lot of the kids who have Down syndrome that you may be familiar with, who function well in school, are going to be in this range. A lot of kids with Down syndrome have IQs above 70. Some even up into that next range, maybe as high as in the 80s. So just because a student has Down syndrome doesn't mean they have an IQ of 70 or below. I think a lot of people think that Down syndrome is kind of the face of intellectual disability. And I think we need to kind of move away from that because it's not always representative of intellectual disability. There are a whole lot of people with intellectual disability who have other things going on besides Down syndrome. People who have moderate intellectual disability may in fact have difficulty with language altogether. People in the severe range are probably going to have difficulty with mobility and language both. People in the profound range of intellectual disability are probably going to have no mobility, no language, at least no oral language, probably no bladder control, no bowel control, difficulty communicating in most ways. So we'll talk more about some of these lower levels of ability or disability here in our summer course, developmental disabilities. If you haven't already had that class, I'm teaching that class in the summer session that starts around June 15th, 16th, 17th, something like that. Some of you have already had that course with me, and others of you may want to sign up and take that one, 5315. So how do we determine intellectual disabilities? Well, the first way that we would determine it with our higher functioning students in the intellectual disability range would be with an IQ test. So we look at IQ first, and if a student is able to perform on an IQ test, we would look at that score and see if they're achieving in that range 70 or below. And then we would look at adaptive behavior as well. Now, what about a student who is not able to perform on an intellectual ability scale? What do we do then? Well, we would look at other means of determining ability. We would look at observational scales. We would look at reports from family and caregivers and teachers and see how a child or a student is performing in class, in the curriculum, at home, etc., on daily living skills, things like that. And we can make determinations about approximation of intellectual ability based upon performance on some of those kinds of things. We look at adaptive behavior that I talked about a little bit before, and that's how a student is able to carry out typical age-appropriate activities. We look at their physical and mental health, how they participate in roles and interactions across home, school, work, and community, and then the context of all of that when we put it together. We look at a student's working memory, how they're performing with skills that require taking in information and then manipulating it and then performing a task with it. How do they generalize information from one setting to the next? How do they make judgments with information that they receive? How well are they motivated? How is their language developed? How are their academic skills? What is their socialization like? Generally, students with intellectual disabilities are less well accepted, less socialized than their typically developing peers because their behavior is often very immature. They behave like students that are quite a bit younger than they are. There's a video that I like to show to my undergrad class, my intro undergrad class, that is about Peter. Educating Peter is the name of the first in the series. And the second follow-up is called Graduating Peter. And it's about a student with Down syndrome who goes all the way through the academic system and is included in much of his academic career. And his mother really presses for full inclusion all the way along the route. And it's very interesting to see. It's a documentary that won, I think it won Best Documentary back in the 90s. Or best, yeah, I think it was Best Documentary. It may have been a short subject documentary, but it won a number of awards. If you're able to find that on Netflix or Hulu or somewhere, you need to try to watch it. Educating Peter is the first one, and Graduating Peter is the second one, and they're both excellent. If for nothing else, the styles, the way they've changed the great big glasses that the teacher wears, and some of the things like that. But I love the responses of the teachers and the parent and the way they interact. You get to see an IEP meeting between the two sides, and you get to see how they integrate Peter into work situations as he gets older. You get to see how he interacts with peers. But toward the end, after they've tried to integrate him in so many ways throughout his school career, it begins in, I think, the third grade, and then moves all the way up through graduation and post-secondary. And he's sitting at home. They've tried to socialize him with a lot of kids his own age, but toward the end, he's sitting in front of the television at home, and Barney, the big dinosaur Barney, is on television, and he is in his happy place. And here he is, 16, 17 years old, and he's watching Barney. And as much as his mom has tried to have him do typically developing kinds of things all through his school career, he's really at his happiest when he's watching Barney. And it's not what mom wants for him at all. She wants him to be on the field with the soccer team and be in the band with the other kids, and to be doing all of the things that his same age peers are doing. But what he enjoys is watching Barney, because that's basically where his intellectual development is. And it's not what the mom wants at all. But I think it's a very telling moment in the film to show, his intellectual development is not unlike his social development. They're all basically kind of stalled at that preschool level. So here are the adaptive behavior areas that we look at: communication, self-care, socialization, home living, leisure, health and safety, self-direction, functional academics, the way the way they use the academics that they're learning to get by in the world, community use, and work. And so we look at all of these areas and see if there are deficits in at least two of these to go along with that low IQ. And then onset during the developmental period, and then we have a diagnosis of intellectual disability. So other things that we're looking for: any unusual behaviors that are related to the specific disability. Oftentimes we have mental health issues related to loneliness, isolation, things like that. Oftentimes we have obesity, other kinds of physical issues that relate to the particular disability. Students with Prader-Willi are very prone to obesity. That's part of that disability, is an insatiable desire to eat. The hunger element of the brain is miscalculated, and it doesn't trigger that the body is full, and so the student continues to want to eat even past the point of being full. Students with Down syndrome often have a heart issue, or they've got problems with the vertebrae in the back of the neck. Others have serious medical problems. That often comes with those who have the more severe levels of intellectual disability, the severe and profound. So we look at intellectual functioning with an IQ test. We look at adaptive behavior with something like the Vineland or the ABIS. We look at medical factors from a physician. And then we look at the eligibility questions that we've talked about. We look at performance on an IQ test. We look at performance on an adaptive behavior scale. And then we look at the adverse effect on the student's educational performance. We always want to begin looking at how we're going to serve the student during early childhood. And certainly most students with intellectual disability have that identified very early on. Sometimes it's missed and we don't learn about it until the child gets to school. I talked about that a week or two ago about a student who wasn't identified until they got to kindergarten. But usually that's noticed by a pediatrician if the child is getting regular doctor visits. Sometimes a lack of development when the child doesn't sit up at the right age, doesn't crawl at the right age, those kind of things. The child's doctor is going to notice that and refer the family to early childhood intervention services. Once the child gets in school, we're going to provide a least restrictive environment that may be in the regular ed classroom, that may be in the special ed classroom, and all the supports that we have there. We want to certainly provide an inclusive setting to the greatest extent possible, and then all the other kinds of things that that go along with an appropriate education. With a lot of students with intellectual disability, they may remain in school past the age of 18 until they're until the year in which they turn 22. A transition plan is required by IDEA, and we want to provide opportunities for them to learn to live and work independently. This just talks about some ways that we do that. I'm not going to go into these. You can look at these on the PowerPoint later. Any questions about that before I move on to a few minutes about speech impairment? Anybody?
Dr. Kevin,
Yes,
on the
ma'am.
app, when you have to complete the app, because I have one that I'm having to complete now.
Yes, ma'am.
I found that it's hard to complete because a lot of those questions we as general ed teachers don't know the answer to. So, and I was told, try not to mark that you guessed on something more than 4 times. So I get the feeling that it's not really reflective of what the kid can do or can't do, because I'm having to guess about a lot of the things, but told I can't put on there that I guess.
Well, I think that's a really good point, Tina. I think that maybe you're not the right person to be filling that out. Is it a student that you have in class?
It's a student of mine, but a lot of the questions, I mean, I can do the things that I see in my classroom, but out of the over 100 questions on that questionnaire, I can answer less than half of them accurately.
Okay. Is there a not applicable option where you can put
Nope.
NA? There's not. Okay. Is there an opportunity for you to take the child and see if they can demonstrate some of those things for you? I mean, could you?
Some of those things I have been doing, trying to get them to do it, but some of the questions, if do they know their way around their community to get from one place to another? You know, those kind of things I can't answer.
Yeah.
And there's several questions about those like that I can't answer.
Can they make their way around the school?
For the most part, yes. And that's what I kind of think about the community, their school environment. That's how I answered it.
Yeah.
But I was just thinking, what do you do when I don't feel like I can answer most of those questions?
Then you know what?
accurately?
I would err on the side of caution. And I would err on the side of caution, and don't say they can if you haven't observed it. Then say no.
Okay.
If you haven't observed it, then say no. Better to err on the side of caution than to give them more credit than you have literally observed.
Okay.
That's what I would do.
Thank you.
Uh-huh. Okay, let's talk for a few minutes before we end things tonight about speech disorders. The thing that, let's see, I want to start on number 5 here, but I want to. Hang on a second. There we go. Okay. The thing that I think is most important to know about a speech disorder is that there are 4 sub areas within a speech disorder or a speech language impairment. We call it a speech impairment. We say that the student is SI. They have a speech impairment, but a speech impairment is broader than just speech. It can be one of 4 areas. Okay. So it can be, and this is the way the federal law describes it, such as stuttering, impaired articulation, language impairment, or voice impairment, such that it adversely affects a child's educational performance. Now, there's that phrase again. So it has to be significant enough that it's going to impair the child's educational performance. So let's go back and look a little bit at that specific definition, such as stuttering, impaired articulation, language, or voice. So there's another word that we use usually in Texas instead of stuttering. We call it fluency. So this is the word that you'll hear most of your speech pathologists use in Texas. You say they have a fluency disorder. So within the realm of speech impairment, the speech pathologist will say they have 1 or more of 4 disorders. The first one would be fluency. That's the rate at which they speak, the fluidity of their language. Is it stop-start? Is it fluid? And stuttering is one of those kinds of disorders. So a fluency disorder. The next one is articulation. Now, articulation is the way the child produces the actual sounds that come out of their mouth. Okay, so my little grandson had difficulty with his R's and with his L's and with his S's, with a number of his particular letter sounds and with some of the blends. And so I may have told y'all this already. If I have, just forgive me, but this is the way one of the ways I demonstrate an articulation disorder. I wanted him to call me Lily instead of grandma. And so Lily is what I wanted to be called. Well, the L is one of the last letters to form, which I should have already known, but I didn't. And so the way he articulated that was wee wee. So he called me wee wee instead of Lily. Well, that wasn't exactly what I was going for, was to be called wee wee. But that's an articulation disorder. Okay. To say the L like a W is an articulation disorder, just like Elmer Fudd says that wascally wabbit, that's an articulation disorder. To replace the R with a W is an articulation disorder. Now, a language impairment is having to do with being able to say the word correctly, articulating the word correctly, but using it incorrectly in a sentence or in a phrase. So once Wesley got to where he could say the words correctly, he still used them incorrectly. So he had an articulation disorder and a language disorder. He would say, I runned really fast. So he could say the R then, and the UN and the ED, but he used it incorrectly in the sentence. So instead of saying I ran, he said I runned. He's using the word incorrectly, He didn't know how to put the past tense together. So that's a language impairment, an incorrect usage of the words in context. And then a voice impairment is when the quality of the speech comes out in a way that's an ineffective use of the voice. So a really high-pitched voice, a really low-pitched voice, a raspy voice, that kind of thing. You may have heard of this effect. In my undergrad class, I shared this with them. The what's it called? The vocal fry that a lot of young women use these days. If you go online and look up vocal fry, you'll see all of these video clips of the Kardashian girls where they talk like this, and at the end of their sentences, their voice goes down and it kind of it's gravelly like that. Well, that's a misuse. I don't think they have an impairment, but they have used their voices in ineffective ways to try to appear sexy or something. And it's what they call vocal fry. Look it up. It's very interesting. You'll hear it in a lot of your a lot of young celebrity women. And then it's bled over into kind of some of that Valley Girl speak. They talk like that. So that's a voice impairment if you do it long enough. And it can damage the vocal cords. So the 4 types of speech disorders: fluency, articulation, language, and voice. So the exchange of information and knowledge among participants is what communication is, requiring a message, a sender, a receiver, and a channel of communication. 2 types of language: expressive language, the ability to produce language, and then receptive language, to comprehend language. So we're producing it and we're receiving it. And language requires both, the ability to receive and to express. So amongst language disorders, we've got specific language impairments, and then you see a list there. We've got delays in language. We've got aphasia. This is the loss of language after it's already been developed. Now, you may have heard in the last year and a half about Bruce Willis developing aphasia. And this is what we're talking about here, the loss of language after it has developed. And then we've got central auditory processing disorder. And that's when you've got the ability, but the brain doesn't effectively interpret auditory information. So it's not that you have a hearing loss, it's that what you're hearing isn't making its way to the brain effectively. So here's the process of speech. I'm not going to go through that. We're short on time. And then the elements of speech. Apraxia down here at the bottom. When an individual has extraordinary difficulty in producing speech that other people manage easily. I do want to mention, well, I think I have another slide that'll talk about this. I'll mention it right here. No, I'll wait. 1.7% of all students receiving speech, special education are receiving it under this category of speech and language disorders. It's actually the second highest category after learning disabilities. Does not include students who receive speech and language as a related service. Now, remember what I told you early in the semester, students in Texas receive speech and language therapy as a instructional service, not as a related service. So in other states, sometimes it's a related service. In Texas, it's an instructional service. More likely, 5 to 6% of students in special ed receiving services for speech and language problems. And this is probably more accurate in Texas. We've got a ratio down here at the bottom, more boys than girls in speech and in language. Now, here's our causes that I did want to talk about a little bit. We've got heredity. We've got some congenital issues where the actual structure of the mouth makes it difficult. A cleft lip or a palate. Sometimes it's a lisp. My husband actually has what's called a lateral lisp. not your traditional lisp, like, some students talk like that with a tongue up here. His is a lateral lisp that goes to the side. An environmental cause, it may be repeated ear infections that cause an inability to hear the way sounds are produced early on. Neglect or abuse, and I want to talk about this for just a second. We have in our family, one of our grandchildren, actually two of our grandchildren, came from the foster care system. And our granddaughter, Natalie, was 10 when she was adopted, and her younger brother, Liam, was 4. And so a 10-year-old and a 4-year-old came out of the foster care system and into our daughter's home and were adopted. And Liam had no understandable language at the age of 4. And I was already receiving speech therapy services, and that continued once he was part of our family. And I believe he's still receiving those services. And he's, let's see, how old is he? He's 6. He's 9. He's 9 now. But there was no structural cause for the disability, no heredity that we know of, all related to neglect and abuse. He seemed absolutely frozen when it came to talking. We would try to talk to him and try to get him to respond, and he would open his mouth and try to get a sound out and would not be able to produce a word. He would come and tug on your sleeve and point to something like he wanted to show you something, to tell you something so badly. And you'd talk to him and say, okay, do you want to play ball? Do you want to have, a cracker? Do you, and he was very eager to communicate, but could not produce sounds. We were told that as part of the background information, the two of them had been in a home situation with 2 drug addicts, and the home was a drug haven. And who knows what else was going on, but that we were told that he was kept in a crib that was turned upside down and like a cage, and he was kept there for ridiculously long periods of time in this cage setting. And we don't know what all he witnessed, or how long he was kept there, or what was done to him while he was in that setting. But he was probably close to nearly 6 before he was talking, and then very, very difficult to understand. But he is understandable now and is coming around. He still has a lot of issues going on, but his speech disorder completely related to neglect and abuse. So it's amazing what those kind of elements can do to the production of language. Problems occur across the entire range of cognitive abilities. So people with very, very low cognition usually have little to no speech. Problems may profoundly affect a student's learning. There are students who have very high cognition who also have speech disorders. Reading difficulties correlate highly with speech and language delays, as you might imagine. If you have difficulty producing sounds, you may have difficulty, you're likely to have a lot of difficulty with reading. Social and emotional behavioral characteristics correlate highly with this. Oftentimes kids who have difficulty with speech are the objects of teasing, experience difficulty in social situations. Other kids have difficulty understanding them, so they isolate from them. And then they often have behavior problems. We have had behavior problems with Liam. And, who knows how much of it is due to speech difficulties and others, other things that are related to his background with abuse. So we assess formally. Our speech language pathologists do the assessment with for articulation, language samples. They take a developmental history, examine the physical structure of the mouth, typical language components to assessment. They look at receptive and expressive vocabulary, the ability to retrieve words. It's called word finding, comprehension and processing of sentences, the correct use of rules of grammar, comprehension of stories and other narratives, the ability to produce language, participate in a conversation. We've got to be very careful when assessing students whose first language is not English, and that we're not confusing English language learning with speech language disability. So we have to determine, does a student have a significant delay or is it just a language difference? Is that problem adversely affecting their educational performance, and are they going to benefit from special education intervention? A lot of this can be dealt with very well with early childhood education. If we intervene early, a lot of these problems can be remediated. Most students with speech disorders are in regular education. We have some pullout, but that usually diminishes as students get older. And most students with speech language disabilities are exited from those services at some point. The speech language pathologist is the one who does most of the work, both evaluation and instruction. Certainly this is true in Texas. They're also the ones who help determine what kind of communication devices might be appropriate, augmentative and alternative communication devices, augmentative being the kind that add to the student's education and their communication, and alternative being the ones that take the place of communication. Parents have got to be involved. And I think we'll wind up there. So, questions? Concerns? Anybody? Questions about intellectual disability, speech impairment? Assignments? Okay, then. We're going to call it a night. I'm going to work on grading and y'all are going to work on assignments, and we're all going to do our best. And if you're a praying girl or boy, then I want you to pray that my knee surgery goes well tomorrow morning, okay? All right. Then I'll hopefully see you next Wednesday night. And if not, look for the other Dr. Cavan online. Okay. But send me a text or a message if you've got any questions. Okay. Hopefully I'll be coming out of that anesthesia sometime tomorrow.
Thanks,
right.
Dr. Cavan. We'll be praying
Okay,
for
y'all
you.
take care, and I'll see you in a
All
few
right.
days. All
Thank
right.
you.
Hope it
Bye,
goes
y'all.
well.
I'll post all this online. Let's see ya.
Bye.
Bye-bye.
Bye.